look, in reality, it is not a long talk. We should understand RIC is coming from where. One time we understand, second time I'll tell you ECG criteria. Okay? ECG ruler, I wrote. This is a variant of ECG ruler. Just I'll tell you, look, I'll make it. Look, it has two sides. 25, be careful, it was broken. 25 and 50. And we are looking, for example, PQRST, PQRST. 1 is placed here, 1 error. And you are finding the peak of second R wave. 1 RR, second RR, where is, for example, here, 100 is like this. If 50, you are using this side.
Yes.
Here, this part is just, look, seconds, if 25. By this also you can measure. It's already 0.04 each. So last one peak is 0.2.
Yeah.
So directly you may measure like that. Though to be honest, we have never done, because when you see one large box, you understand that it's 0.2. No need to put a ruler. But if you, this is for 50. Look, one large is 0.1. And here are standard intervals like PQ interval, ST interval, QRS duration, but it is a bit average. Look, QRS 0.08, 0.11, up to 0.12. 12 is, I thought, border. PQ, PR, 0.12 to 0.20, they have taken from 0.17 to. But anyway, for example, if it would be 0.16, you'll never tell that it's short PR. You may take a photo of this, you may give your friends, you may look at this. I can't. Just a minute.
ऐसे भी देख इस टाइप perfect.
So, determination of pacemaker. Determination of pacemaker means pacemaker is coming from where? Yes. No, it was a rhetorical question. I mean, it means we need to answer if in front of you is ECG. It's first question. There are a few questions. Will not try because it is not powerful. To send a PPT version to the site. If I'll find, I'll send. It is ECG basics, yes? ECG basics. Now look, we have first class pacemaker, second class pacemaker, third class pacemakers. Yesterday and the day before yesterday we spoke about impossible. We'll die. So when decoding ECG, there are a few questions, at least, which rise in front of every clinician. First, coming from where? Second, it's regular or irregular. Don't indicate that. Third, heart rate. Fourth, electrical axis. Then, pathological changes. Pathological changes is diverse of variants, so we'll not speak about this. It's already cardiology. We are speaking about ECG basics. So this year you'll answer to 3 questions. Heart rate determination, which we know, axis, which already we know, and determination of pacemaker. Now, schematically, I'll draw few numbers. This is sinus node. This is AV node. You can see, yes, I think from the. Yes?
Yes.
His bundle. Yes. Right, left anterior, posterior, then Purkinje fibers. Now we should today speak about terms like anterograde and retrograde. Anterograde, which is its normal direction, retrograde, opposite direction. And I told you, first of all, why I thought that today's talk should not last too long, because yesterday, day before yesterday, these physiological parts, once more I told where, how impulse is passing. Now, and I told among all other issues that first of all, the depolarization of the part where is localized the pacemaker. Independently, it's natural or even artificial or ectopic or sinus. If it is normal sinus rhythm, it is called normal sinus rhythm. And like this. Pacemaker is here. Look. First of all, we have the polarization of right atrium, then left atrium, then impulse will go downwards. It is anterograde. This direction. Then anterogradely, it is passing through the all parts up to Purkinje fibers. So, depolarization of SA atria leads to formation of P, yes, and depolarization of ventricles, yesterday we spoke QRS formation. For example, like this.
Yes.
P is before QRS. Why before? Because at first we have depolarization of atria, then ventricles. QRS should be normal, so less than 0.12 narrow. When I'm telling normal, it means narrow. And the polarization of atria is like this. Yes? If I go back to heart electrical axis, look. So it's approximately has the same direction as +2. That's why P2 was greater than P1 than P3. The largest P we expect to get there. So P will be positive. ECG criteria, write down. ECG criteria of normal sinus rhythm. Let's quickly. ECG criteria of normal, like this you should answer during the exam. ECG criteria of normal sinus rhythm. When you are telling it's normal sinus rhythm, you should tell why. Because look, next year we will pass, for example, sinus tachycardia. First criteria is the same. Rhythm should be sinus. Then above one. So first, there are lots of criteria, main item. First criteria is this. Positive P wave before QRS, especially in second lead. Like this. Positive P before QRS. Positive P before QRS. Yes? But in AVR will be opposite. Look, this is AVR, it is minus AVR. For me not to write on the screen with the marker, yes? It is minus AVR because this is plus AVR. So we'll have negative P before QRS in AVR. Like this it will look. Like this, look. Okay, let it be like this. Huh? T is also negative, doesn't matter because most of the waves are negative. minus P before QRS. Agree? Third criteria. So this is outside. It's all together. QRS is less than 0.12 seconds, which is normal. It's ordinary. Fourth criteria. Heart rate is equal to 60 to 100 beats per minute. It's a bit disputable. Why? Because if we are speaking about sinus tachycardia, everything is the same, but heart rate is above. That's why we are speaking about normal sinus rhythm, not just sinus rhythm. And some tiny changes we have. For example, STT changes we may have in tachycardia. Why? Because if we have tachycardia, diastole shortens. If diastole shortens, blood supply is becoming less. So it's relative coronary insufficiency. Why relative? Because if tachycardia is over, these STT changes are coming back to normal. Okay? Unless you go. Everybody has seen? You are telling yes. That's fine. You have started from there, right? Counterclockwise. Okay, next. Next criteria is very important again. And by the way, nobody is allowing you to edit criteria. I had such kind of students. They are telling first and they are telling it's okay. If only one would be enough, we are not, I don't know, meds. Yes, we are not crazy. What is enough? Enough is not enough. P QRS ratio is 1 to 1. 1 P, 1 QRS. 1 P, 1 QRS. And but to be honest, the most important are these first two. First two. Why? Because for example, we may have lead reversal. In this case, in first lead may appear negative. It is also tight. And P wave in the same lead should have more or less the same appearance. I'm writing P is constant, okay? Not to write so long. Constant means that it has the same appearance. For example, in the same lead cannot be one P like this, second is like this. Now let's make a pause to understand one issue. Let's imagine that P which came from sinus node looks like this. If we have ectopic focus, for example here, it's not enough in our district. No, a bit later it's allowed in our program. It's coming from here. We will have, for example, like this. They will be very similar. Even if you don't have normal P, you cannot distinguish by ECG. By electrophysiological study, you may understand it's coming from ectopic focus from atria. Accordingly and logically, closer your pacemaker to the sinus node, the P will have similar appearance. Far from it is becoming changed. For example, if we'll start from here, P will have another appearance. It's difficult to tell which. For example, maybe less in height, maybe polarity is another, shape is another, okay? But if you have something to compare, you'll understand that it's not the same. But of course, only based on ECG, it will be very difficult. But this is very important. Now look, if, for example, if pacemaker will be localized here in atria, like at the midpoint between SA and AV, or atria and ventricles, look, part of the polarization will be retrogradely, part anterogradely. So we'll have biphasic P. It's also possible. We are speaking about secondly, because in V1 to have biphasic P is completely normal. Yes. Or that's why second is the most important here. Was clear. This is a particular case. But we'll speak about other particular cases. So now this is the only normal pacemaker. You may write down determination of pacemaker. Based on this, we have sinus rhythm and non-sinus rhythms. Okay, non-sinus rhythms. Now that I forgot that we have this option. You may write here. Write this. So non, by default it is on black. Non-sinus rhythms. Also, we may call them ectopic rhythms. Ectopic. Always remember, this is already ectopic. This is also ectopic. Out of its borders is ectopic. Even 1 millimeter, 1 micrometer. Of course, if it is 1 millimeter, we cannot understand, but by ECG. But by electrophysiological study, when we insert electrodes invasively and we measure potentials directly, there already we may do. I didn't speak about this, next year we'll speak. It's in arrhythmias. One of the studies, like, look, we have ECG, and we have ECG-based methods. For example, 24 hours ambulatory ECG monitoring, which is called Holter monitoring. This is to catch some arrhythmias, because ECG lasts a few seconds. By the way, in a lot of other textbooks, you may find a lot of tricks how to measure heart rate. Method of 6 seconds and so on. But all are based on this 60 divided on RR. Usually 300 is just convenient variant. Just a minute, sorry. Hello? What is this? Ha. Short var inerse är så långt bak från konsten. So, there are other methods. And for example, treadmill test.
Yes.
Patient is running on a runway or bicycle riding, and parallel ECG is registered. This is to diagnose coronary artery disease, latent forms. Of course, if patient has myocardial infarction, has STEMI, but it's contraindicated. But anyway, there is EP, electrophysiological study. EP. This electrophysiological study is heart electrophysiological study. It's another discipline. It's another specialty. People are going and studying. It's invasive arrhythmology. Like EP is diagnostic part. Then based on EP, you can perform a lot of surgical procedures, treatment methods. Based on electrophysiological study, you may understand. It's like very simply, if you would imagine, electrode is inserted via vena cava superior inferior system in the right atrium, and around the sinus node, you register potentials. AB, atria, His bundle, it's called histogram or nodogram, and so on, up to Purkinje fibers. If there are accessory pathways, like Kent's bundle in WPW, you may find its exact direction, position, because it has 11, 12 positions. Very simply for the students, we are telling that we have left-sided or right-sided, connecting left atrium with left ventricle, right atrium with right ventricle. But in reality, there are a lot of variants. And why it is important? Because then we may perform ablation, like to destroy this pathway by radio frequency, by laser, or infrared catheter ablation. It's catheter ablation, but which method you are using? It may be a radio frequency, maybe infrared, maybe laser, doesn't matter. Matters, of course, there are advantages, disadvantages. But first of all, you need to find. And based on this EP, these potentials giving and registering, even you may provoke some arrhythmias to understand that you are on the right side before destroying. So its invasive procedure should be clearly indicated. Now, and based on this, we can perform something which is called intracardiac mapping. Like you are getting a map of the heart inside of exactly this patient. To understand that they say not exactly is where here, this bundle is coming how, okay? By EP you may understand that it is coming from here or from here. But in daily practice, you are not doing each day EP. I mean, clinical cardiologists, not invasive arrhythmologists, they are doing. because if rhythm is coming from here, first of all, it's not dangerous. And we have intracardiac mapping. Intracardiac mapping. Non-sinus rhythms are three. Maybe atrial, maybe AV junctional, and maybe ventricular. Or it is called also idioventricular. Do not confuse. Yes, sinus node is in the right atrium, but sinus rhythm is not atrial rhythm. Philosophically, it is also atrial rhythm, not ventricular, but by definition, we have sinus and non-sinus rhythms. So even if it's coming from here, it's already atrial rhythm. Now we may distinguish or not, it's another question. So we have atrial, AV junctional or AV nodal rhythms, and ventricular rhythms, which means that when we are telling that rhythm is coming from atria, we don't mean atrial cardiomyocytes. We mean conduction system, usually. Though sometimes, for example, pathological changes, structural changes, like fibrotic tissue, scar, may be a source of arrhythmia. It's called, for example, scar VT, scar-mediated ventricular tachycardia. But it's another question. It's about arrhythmia, so we'll speak. Now look. Though from another hand, it is also arrhythmia already. Arrhythmia are heart rhythm and conduction disturbances. Now, when we are telling that ventricles, we mean that somewhere, for example, from his bundle branches. Maybe in rare cases on the level of Purkinje fibers, but anyway. Okay, so may come from here, may come from here, like junctions like this, and may come from here. And ECG criteria are different. Very simply, very often, these two, where are these two? Atrial and AV junction, very often. Very often are called supraventricular. But for rhythms, usually we are not telling supraventricular rhythms. But for example, for extrasystole, we'll tell supraventricular or supraventricular tachycardia, which means either atria or and ventricular. Why? Because look, if atrial or AV junctional, mainly QRS is less than 0.12 seconds. Ventricular already will be broader, wider. By appearance also there. So up to ventricular, QRS will be normal. From atria, from AV junction variants, now we'll speak. Okay? Now. So atrial. Let's take one exact case, because it is clearly, we can see on ECG, when atrial rhythm, first write down atrial rhythm, particularly it is called lower atrial rhythm, low atrial rhythm. It is coming from lowest parts of atria, here. If you remember, it is upper part of AV junction. It was period when it was called upper part of AV junction. Okay, now it's called lower atrial rhythm. And in medical English, instead of lower atrial rhythm, very often is used another term, coronary sinus rhythm. If you remember, there was coronary sinus. So coronary sinus rhythm. Here I'll show, then I'll show. It is here, your pacemaker. How it should depolarize atria? Direction. Only retrograde, because it's on the lowest part, it's at the bottom of the atrium, let's say. How to tell you? For example, let's imagine that on your right side, okay, pacemaker is localized there on the ceiling, on the corner, upper. That it should depolarize this room, which is atrium. Let it be atria or right atrium. Direction will be up to down. Now imagine that instead of this, pacemaker is to flow. It cannot go down. Will go down, down are ventricles. Upper, only one way, retrograde. So the direction of depolarization is against normal direction, retrogradely. So look retrogradely to the atria, anterogradely to the ventricles. So you have negative P before QRS. Okay? So you may write down that in this case, we have the retrograde depolarization of atria and anterograde depolarization of ventricles. So retrogradely to the atria, or atrial depolarization takes place in retrograde way, ventricular in anterograde way. So many times it is changing. This is sinus node, let it be the AV node, and it is semantic view. This is called coronary sinus rhythm. Here is your pacemaker. So this is depolarization of atria, retrograde, and anterograde to the ventricles. ECG criteria. First criteria. In second, third AVF. This time they are also coming because they are very close. Negative P before QRS. Accordingly, in AVR, we'll have positive, because always AVR is mirroring second. Something like this, like this, like this, like this. Mirroring. Positive P given before QRS. QRS is normal. Because further spread of impulse is unchanged. Also here, heart rate is a bit less. But of course above 60. Because 40 to 60 is AV node already. Maybe for example, heart rate maybe for example 70 to 80 like this. Okay? Maybe a bit less. But it's not a criteria. If this you see clearly negative P before QRS, heart rate now is 75 and so on, you don't pay attention too much because from the lower parts of atrium. Okay, was clear. Now, we cannot duplicate this now. AV junction rhythms. AV junction rhythms. We have two variants here. Look, there are a lot of science I'm using, like maths systems. For example, A and B, you cannot find A and B. You may find, for example, variant this one or two, doesn't matter. Variant A and B, we have two variants. It is, remember, second variant. First was coronary sinus rhythm. So we have atrial rhythm, but atrial rhythm, particularly lower atrial rhythm, because if it will be very close to sinus, we cannot distinguish. If it will be midway, we can distinguish it by phasing. But here, because it was midway, upper part, for example, was here. Upper part will be anterograde, retrograde, lower part. In AV junction rhythm, now look what I mean. Schematically now, here is AV node, okay? AV node. Here are atria, here are ventricles. In variant A, atrium ventricle receiving pulse at the same time, simultaneously. Again, atria are depolarized retrogradely, ventricles are depolarized retrogradely. Accordingly, for AV junction rhythms, from the start, let's write down that heart rate is 640 to 60 impulses per minute. Impulses, and then it becomes beats per minute. Now, the polarization of atria will have what? Negative feedback. And here, normal QRS. ECG criteria have AV junction rhythm. Altogether we'll write down, okay? Okay, in variant A, write down. In second, third AVF, QRS complex without P. Absent. Why? Because it happens at the same time. It is fused with QRS. Logically, it should be negative P. But this negative P coincides with QRS. It's not before or after to be seen. Like this is your QRS, this is your negative P. It's fused. We don't see. Either before or after. We see something like this, for example. Okay, QRS, and so on. No P. Absence of P waves. Heart rate is a criteria. QRS is normal. Do not ask me why, but this fusion doesn't have significant impact on duration of QRS. We don't have growth QRS. So QRS is normal. Second criteria you may write down. So in AVR also we don't have P. Because we don't have, again it is fused. Heart rate, okay, you understood? Okay. Of course, look, it is like from the middle part of AV junction. From the exactly instantly from AV node. And variant B in English literature sometimes is called infranodal. Now look, this is AV node. Here are atria, here are ventricles. Now I'll change the color. You cannot understand. I'm selecting blue, it is giving green. Imagine that it's from here. Below AV. But if you remember, AV junction was larger. Again, all are ectopic. All. Out of sinus. Not all are ectopic or no sinus rhythm. Why ectopic? Because, for example, we have atrial fibrillation. It's also no sinus rhythm. But it's arrhythmia. We will not speak about this. We are speaking about passive ectopic rhythms, which are helping heart to protect from long periods of asystole. Now look. It is closer to the ventricles, yes? So first of all, we have depolarization of ventricles. Normal QRS. Normal QRS. Then impulse is spread to the atria, retrograde. Again, retrogradely, anterogradely, and negative P. So, ECG criteria. In this case, negative P after QRS. In second, third AV. So, if before QRS, it is coronary sinus rhythm. If no, or after, it is AV junction rhythm. All others are the same. Infranodal variant, this is just. Now look, it looks like this. Then I'll show you. For example, Q, R, S, negative, negative. This may be T. T is not a criteria. The main idea that your negative P is coming after QRS. It is fused with T, it has chest configuration of T possible. Main that this is coming after QRS. Once more I'm telling, always we should try to find P. Sometimes it is hidden on the background of tachycardias and so on. Always search for P, cherchez la P, because P is telling you rhythm is sinus or non-sinus. In this context, within this context is the most important maybe issue. And QRS is normal in both these cases. Was clear. Third variant, ventricular. This is SA, this is AB. One secret, which usually like this is not written in textbooks. I am not mentioning this. AV node, look, may give its impulse to the atria if, for example, above standing structures are not functioning. But it will never allow any impulse which, like to say, is born in ventricles, so below it, to pass through it to the atria. Now you may tell, but what about infranodal? Infranodal is a part of AV junction. AV junction, let's say, is not allowing, okay? For example, we don't have any case, but impulse from here is passing to the atria. So, in this case, pacemaker is localized in conduction system of ventricles. Either is bundled branches in one or Purkinje fibers. So let's imagine that it is localized here. If we try to change the color, for example here, maybe here, but let's imagine that in the right branch. First of all, we'll have depolarization of right ventricle because it is localized there. Then, with a delay, impulse will be spread to the left ventricle by cardiomyocytes. Why? Because this branch has not received. From where to receive? From another. And we have depolarization of left ventricle. If it is localized here, we'll have opposite picture. At first, left ventricle will depolarize, then later right. Accordingly, QRS is becoming longer in duration. So look, first ECG criteria. So idioventricular rhythm. First criteria is that I'll change the color. It's annoying color. Another annoying color, please. Idioventricular rhythm. First, heart rate is less than 40. For sure. Including Purkinje fibers, even less. Second, QRS complexes are more than 0.12 seconds. It's called wide or broad. They are deformed. Their configuration is changed. They are deformed. They are deformed. And we have STT discordance. Now I'll explain. There is STT like this. No, the ST minus T. STT. Discordance. Very simply, discordance means opposite direction. I will explain. Write down discordance is opposite direction of ST segment and or T wave towards main wave of QRS complex, or in relation to main wave of QRS complex. From previous classes, we have already learned that QRS complex usually, if we will not count equiphasic complexes that R is equal to S, either is positive mainly or negative, depending. R is prominent or S. Q, you know, non-mandatory, or Q, okay. So, variant, this variant. For example, your QRS complex is like this, yes? Tall R. ST is going down. It is called ST depression. Always remember, waves may be positive or negative, but segments may be elevated or depressed. Now, below the baseline is called depression. ST depression and or negative T. Maybe even together. For example, will be like this. I told you. Not that much. For example, even with negative T. So this is negative T, this is your ST depression because it's below the baseline. But if your QRS complex is represented by deep S, we'll have ST elevation with positive T. With or without doesn't matter. It is called ST elevation. Depends. Initially, QRS complex had which configuration. Okay? And last criteria. Here, what about P? Tell the P is absent is wrong. Because it is even maybe present. But P, QRS, this normal 1-to-1 ratio is lost. How it can happen? Very often, right now, the ventricular rhythm appears on the background of complete AV block, third degree. Atrioventricular block, about which we will not speak today. When atrial and ventricular rhythms are completely dissociated. In this case, look, I told that AV is not allowing anything to go here, but what about atrial? How they are living? SA is giving impulse to the atria. These below standing structures, ventricular conduction system, to the ventricles. But they are not related to each other. So, you may see P waves sometimes on this ECG, but they are not related to QRS complexes. They may be before QRS, after QRS, maybe fused and superimposed with the QRS. But they are not related. Okay? Of course, here we have variance, by the way. We have variance. For example, the same AV nodal. There are distal blocks and so on. Configuration when I'm telling the QRS is narrow, I'm telling the classical issues. There may be variance. And even we may tell this idioventricular rhythm, even we may tell it is coming from the right or from the left. Based on ECG, without electrophysiological study. Look, if it is left ventricular origin, yes, LV origin, we'll have right bundle branch block pattern. If we have right ventricular origin, it is resembling LV pattern. Why? Because look, if it is localized here, it means, and left is not receiving, it's the same if we have left bundle branch block. In this case also, impulse, before in supraventricular rhythms, impulse was coming and more or less equally was going to the ventricles. Now it is localized in one of them. That's why with the delays. The same happens when for some reasons this conduction part is not working. Again, the polarization of left ventricle will be due to after repolarization of right ventricle by cardiomyocytes. That's why left ventricular origin, we have RBBB pattern. I'll not tell you now. I mean, it is already next year topics. And right ventricular, we have LVBB pattern. Okay? Was clear? If you have done this, now let's go to the slides. We don't need this. I think we know this. And we'll see after a month. Next one. I don't know exact dates. Anyway, rules we know. QT interval, corrected QT, the conventional pacemaker look the same. Then above this, supraventricular narrow QRS complex, ventricular wide QRS complex. And here, these are the images. Look, what is this? All are in second lead shown. First, still is showing what? This first. Which rhythm is it? Negative P before QRS. Coronary sinus rhythm, yes. Atrial, particularly low rate. Negative P before QRS. By the way, up to down, you'll see that RR is prolonged because we have more bradycardic rhythms. These two are AV junction rhythms. P is fused with QRS and not C. QRS negative P, then T. I've taken from that textbook. It's a photo, then on the slide, that's why some quality is lost. But anyway, the meaning is the same. Negative P before QRS. So, and this one is idioventricular rhythm. You can see broad QRS complexes. Negative T with disorders, D4. Heart rate, if we'll count, is bradycardic. And P waves, look, here for the P wave. Here also. They may be even regular if we have complete AV. P interval may be constant. But for example, this P next is fused with QRS, that's why it's not C. But 1:1, this ratio of 1P1 QRS is lost. This is determination of pacemaker. Was clear? And second part of our today's talk, and we are finishing on this, ECG changes in hypertrophies. And by the way, look, this we'll speak next year. This is called wandering pacemaker. Wandering. In Russian literature, it's called migration of pacemaker. Sorry,
Which phone you have, actually? iPhone. Old one. இந்த phone bro வச்சிருக்கான் அவன்.
8 or 6.
6 iPhone 6.
6s.
But dual camera, iPhone 6.
It's not dual camera. It's only one single camera.
Single camera. No. iPhone 6 it's a dual camera I'm saying.
Yeah. iPhone 6 From 7 onwards it's dual. Scheduled 20.
Which model you are talking about?
i6. The Air model.
Air, okay. Air model. I'm talking about the normal iPhone. You going to say Air. Air and all now only came. The iPhone 17, yeah. iPhone 17 only Air.
No. 7 plus 8 plus. I had 8, 11, 13. And now if God grace me, I will upgrade to 17. All red edition only. आपने टेंशन आऊँगा.
See, September 2025 and then that one is the same or what?
6S.
Sorry, but you said yeah.
Sorry, my bad. Full pharmacy
Pharmacy, yeah.
gastritis, pneumonia, UTI. എല്ലാം ഉണ്ട്. upper respiratory infection. Lower respiratory.
Middle respiratory.
She's fed up of me. He's telling I have all sickness. Medicine.
Best doctor.
Dhanush is the best doctor of third year. Please, Dhanush, be a doctor. Please, 6th year, be a doctor. No, never drop the course.
Is there
Started, finish it.
is there anything like best doctor according to the course?
No, you have 2 certificates. One is blue and green.
Green.
Yes, yes. Blue and red.
Diploma. Red diploma.
Red and diploma and blue diploma. Dhanush will get red diploma.
Oh,
Sushma
yeah.
also will get red diploma. Chechi is also fed up of me like you.
Outside there is snowing.
You will get blue, even I will get blue. They 3 will get red diploma. Red, what is that called? Graduation certificate.
I don't want anything.
Even I want. But I want to drop the course. But I
No,
want.
I don't want any explanation or anything like this. Yeah.
Explanation. Then without exams, how you pass it is stupid.
Why?
Cry. Come on, cry. निश्चित कैसे संभाल रहे हो उसको नहीं पता ना भगवान पर मैं भी सिर्फ भगवान पर ही है भगवान चाहिए तो करेगा हम आधा भगवान आधा रेस्ट पूरा री एग्जाम में गया तो भी कुछ प्रॉब्लम नहीं है रो रो के निकालेगा बट हम देवा नहीं है कुछ क्या हो रहा है होने दो Just chill. लीडर बोल दिया
So, hypertrophies. Hypertrophy means increased thickness of any chamber. This you know. Now, logically, write down that in hypertrophies, electrical activity is increased. Of the hypertrophic chamber. For example, if P is standing for atrial depolarization, P wave changes will have, and P will become like bigger. Now, which variant and so on, we'll see. This one, right? Wandering pacemaker means that it is migration. So, supraventricular pacemaker, look, normal P. Before QRS. Then P is changing the configuration, PR interval decreases. So it means that atrium has come a bit lower. Then negative P has come lower parts of atrium before QRS. Then disappears. So AV junction. Then is coming after QRS. Then is again going back. Then lower atrial rhythm, then is coming to this. It is called migrating pacemaker, but it's already arrhythmia, so to speak. Determination of heart rate we have done. So ECG changes in hypertrophies, but for this I need only one load. Because on this I cannot. Then examples will. So let's start from atria. For atria, we are using term enlargement. We are not telling hypertrophy of ventricles, but enlargement of atria.
This one we have to start. This one is finished. This one is already. It means 85. So 15 gain something. I think we finish at like 4 only.
So for ventricles, we are using term hypertrophy for atrial enlargement. Accordingly, we have right atrial enlargement and left atrial enlargement. If you remember, we have formation of P from 2 components. Yes? No, this I'm just erasing not to make extra troubles for the cleaners. Now, milliliters and duration less than 0.1 seconds duration. And if we measure distance between these two peaks, which are not seen normally, it will be less than 0.02 seconds, because exactly 0.02 seconds takes for impulse to right from right atrium to left atrium. Okay, this is whose? What's that? Is this somebody's? Was here? I didn't notice.
It's fine.
It's yours?
No, sir.
Now, it is normal. No. For right atrial enlargement, schematically, I'll show this right atrial component is becoming like this. We have told peaked, acute, even hyperacute P wave, and this is left atrial component below it. Such kind of P waves are called P pulmonale. P pulmonale. So this P is taller, more than 2.5 millimeters, but duration is normal. Less than 0.1 seconds. Why? Because look, that mass is increased, electric activity is increased, it's clear. Should finish here, yes? But instead it is finishing here. Anyway, it manages to finish with left atrium. That's why total duration is unchanged. But main wave like is represented by P. So by right atrial component. Most of the P wave is right atrial component. Left is not seen there. So such kind of P waves are called P pulmonale. Why? Because it's very typical right atrial enlargement for chronic pulmonary processes in COPD, for example, bronchial asthma, and so pulmonary embolism in acute cases. P pulmonale best seen in second, third AVF, V1, V2. Why V1, V2? Because it's anterior part, yes, and right parts were projected on anterior chest mainly, left were behind. Why second, third AVF? Because it is inferior, close. And what about V1? This is in second. In V1, we see such kind of issue. So left atrial component either disappears or is not significant. Mainly his right atrial component, plus component, is more prevalent. Okay? This is right atrial enlargement, P pulmonale. Was clear? May I go next? Now, left atrial enlargement. For left atrial enlargement, this is right atrial component, which is normal. This is left atrial component. So total duration of P wave is increased more than 0.1 seconds. The distance between two peaks is becoming usually more than 0.02, but in lecture it's written 0.04 even. Anyway, more than 0.02 seconds. We have like two hands, no-cheek bifid P wave, which is called P mitrale. Mitrale, because it's very common, though not only, in mitral stenosis, mitral regurgitation, when we have left atrial enlargement due to volume or pressure overload. P mitrale, best seen in first, sometimes second, AVL, V4 to V6 leads. P mitrale. In V1, we have disappearance. So second component negative is becoming more prominent. Left atrial component. This is a schematic view. In reality, P pulmonale is like this, for example. So it is like this. Sometimes maybe P pulmonale, even like this. It is arch five images I have shown you. Look, right atrial enlargement, tall, 2.5, pointed QH, pulmonary, you see? In second, third AVF especially. In V1, look, this right atrial component is more prevalent. Left atrial enlargement, notched, bifid, F-shaped Q-wave, P mitrale, E leads. In V1, negative is becoming more prevalent. Look, P pulmonale, P mitrale. P pulmonale. Q-waves are too, especially in lead second, third, with AV4, V1 and V2 as well. To diagnose right atrial enlargement, we have following criteria. P is more than 2.5. V1 or V2, P is more than 1.5 small boxes. But anyway, usually compare these two information, not only in millimeters. Cause of right atrial enlargement is right ventricular hypertrophy from pulmonary hypertension. And this is P mitrale, this is negative deflection, negative component of left atrium in V1. You see? To diagnose LAE, you can use the following criteria. Second, between notched peaks, you see more than 0.04 seconds, or negative deflection is 1 box wide, 1 box deep, 1 millimeter. Wide, 1 millimeter deep. So horizontal size and vertical size. Normal. In case of common cause of left atrial enlargement is left ventricular hypertrophy from arterial hypertension already. Okay. Now we have ECG changes for ventricles, ventricular hypertrophies. Just ECG criteria will write, then explain. Left ventricular hypertrophy. First ECG criteria. Though first, second is a bit relative, you may number somehow. Then heart electrical axis is shifted to the left. Left axis deviation. Which means that R1 is greater than R2, greater than R3, or R1 is 3. Second criteria. If you remember V in limb leads, R wave was increasing in size from V1 to V3 up to V4, where V4 is maximum, that is declining. Now, R in V5, V6 or V6 is becoming more than R in V4, more equal. It should not be. It is the most important criteria. Next. In V1, V2, we may have deep S waves. Because it's opposite to V5, V6. If there were tall R waves, here we have deep S waves. Fourth, in V5, V6, we may see ST depression and T wave inversion, negative T, maybe. It is related to ischemia, relative ischemia, because hypertrophied wall needs more oxygen. But it's related to hypertrophy, not because coronary artery is occluded. Okay? We may have, we may not have. Fifth, intrinsic coil deflection time. Deflection time. In V5, V6 increases. More exact, it is becoming more than 0.05 seconds, but it's not, you may memorize, may not memorize, doesn't matter. What is intrinsic coil deflection time? Intrinsic coil deflection time is this. If I write one R wave like this is R wave. You cannot understand why. By default, it is leading to eraser. This is R wave. This is the start of R wave. This is the peak of R wave. The time between start and peak is called intrinsic coil deflection time. So from the start up to the peak. As you understand, if wall is thicker, this time is becoming is this intrinsic coil deflection time? In reality, it is the time during which impulse from subendocardial layers is delivered to the subepicardial layers. Because the polarization wave goes in this direction. I'm sorry. Alo. Привет, Игорь. Он сосишка. Ha. No, let's say, let's see. Doing something. So, So intrinsic coil deflection time is the time during which impulse during the polarization is spread from subendocardial layers to subepicardial layers. Okay. And sometimes we have quantitative criteria, a lot of ESTAs, corner voltage criteria. You may read from textbooks. By the way, for this year I will give you ECG textbooks. This is enough. Next year, please. If you want, I may give. I may send. You need just tell your leaders to remind me. But one which is the most commonly used is Sokolov Lyons criteria. Sokolov like this Lyons criteria. These are Soviet authors, but anyway are still used in US guidelines, European guidelines, and so on. What is this? Sokolov Lyons criteria to diagnose. It was before echocardiography. Nowadays, for more accurate measurement, we are using echocardiography, at least, if not MRI and so on. That's why nowadays we are telling signs of hypertrophy. Then it was called just hypertrophy. So, for hypertrophic left ventricle, we need this criteria R in V5 or in V6, where it is tallest, the tallest R size, plus S in V1 or V2 is more than 35 millimeters. So we are taking the tallest R in V5 or V6 where it is tallest, and S in V1 or V2 where it is deepest, and summarizing their length, their amplitudes. If this, there is a difference, male, female, above 40, below 40, the age and so on. But 35 is like some average value. Okay? Normally should be less. Now how it looks like on ECG. This please do, then I'll try to erase and show you. This part we don't need. Now look, for example, I'm taking V4, V5, V6. Normally it was like this. Yes, V4, V5, V6. The tallest was here, maximum. In left ventricular hypertrophy, it is becoming like this. More. Okay. And that's all. I think, but one moment. Here, when we are telling R, we should not forget that also we have S in V4, V5, V6. So when we are telling that R is greater in V5, V6, or equal to R in V4, we mean that R is equal to R plus minus S, negative S. Look, because maybe we'll have this situation, V4, V5, V6. We have in V4 like this, in V5 like this, and in V6 like this. Now if we take only this, it's not hypertrophy. Yes? But here if we'll compare, R is equal to S. So total your vector is 0. In comparison with this 0, V5 and V6 are more positive. So this also should be taken into account. So that this is what I mean when telling R in V5, V6. We should not forget that we may have also S. Of course, there are more complex moments. We may have combined hypertrophy of left and right ventricles. But anyway, this is enough. Okay? This is clear. And the last one, right ventricular hypertrophy. Sorry. Here alpha was less than 0 degrees, more exactly less or equal than minus 30 degrees. Then because up to minus 0 is physiological, yes or no? Now, right ventricular enlargement. Right ventricular hypertrophy, I'm sorry. Right ventricular hypertrophy. First criteria is that we have right axis deviation, which means that R3 is greater than R2 than R1, or R3 as 1, or alpha is more than usual plus 100 degrees. First criteria. Second criteria, R in V1, V2. Why V1, V2? Because V1 and V2 are right precordial leads. That's why there were left precordial leads, V5, V6. R in V1 and V2 is tall. Accordingly, we have deep S waves where V5, V6. It is in general. Next, in V1, V2, we may have ST depression, like this I'm marking, or negative T. And or negative T. Again, relative coronary insufficiency, like that. Relative coronary insufficiency. Next criteria is intrinsicoid deflection time in V1, V2 is increased. Intrinsicoid deflection time. Look, when I'm telling V5, V6, maybe first the ideal also, but V5, V6 are mixed. Was clear. And last one, I think you have this in your questionnaire, special types of right ventricular hypertrophy. Special types. Or specific types. Specific types of right ventricular hypertrophy. They are three. First type is called RSR prime type. Second type is called R type, and this is called S type. RSR prime, R and S. RSR prime type is like this in V1, V2. More prominent is this configuration R, S, R. If you remember, and R prime was greater than R. It is very similar to right bundle branch block pattern. So, but it's variant of hypertrophy. This is given, you know, what for what? Because before echocardiography, by this we can judge, about the cause. It is caused by what, for example? Like for example, atrial septal defect is very common. Because of this variant of hypertrophy. Next, R type. R type means that in V1 and V2, we have the most prominent component is tall R wave. Tall R waves. For example, like this, either like this or like this. So Q R R S. All other criteria, of course, right axis deviation, so on, are remaining very often. S type, that from V1 to V6, we have deep S waves, like this. V1, V2, V3, V4, V5, V6, we have this kind of, and so on. So deep S waves everywhere. Very often you may write down that this S type special variant, especially I didn't tell you during hard electrical axis, to tell you here. Which means that not only from V1 to V6, just I didn't continue there, we have deep S waves, but also in first, second, third, we have deep S waves. It may be like extremal axis deviation, but it is not by anterior posterior. It is by transverse axis. If you remember, you have finished with this. If in first, second, third we will have negative QRS, it's extremal axis deviation, but by anterior posterior. Also, I told you that there are three axes. This is anterior posterior, longitudinal, and transverse. So this S-type hypertrophy, in case of S-type hypertrophy, very often by transverse axis, apex is going backwards. That's why we have this S, deep S configuration. Okay. Now let's go forward and complete this. About practical skills and so on, please during consultations, okay? I'm still working on them, but we'll be, and today remind me to send you samples for images and so on, which is in your practical skills part. Hypertrophies. Look. Hypertrophies. In left ventricular, and V1 and V6, this is normal. In left ventricular hypertrophy, look, we have deep S wave and tall in V6. In right ventricular, maybe opposite. Okay, right ventricular. Tall are waves, like this. And deep S waves we may have in V6. Right atrial and ventricular hypertrophy. Look, R3 S1. Right axis deviation. If we measure intrinsic weight deflection time, it's impossible on this, but it will be increased. So first is right axis deviation, then was tall R waves in V1, V2, but this is not that variant. Look, in V1 and V2, we have S, mainly S type of hypertrophy. So not always is criteria. Sokolov lines criteria. S in V1 or R in V1, V1 or V2. Okay? And or if we have tall R in AL, it also may be considered as a left ventricular hypertrophy. Look, R1 is greater, R1 S3, because here R2 is greater than R1, but look what is the problem. Here they have Q wave. It is confusing us.
You are also going to get. I am not taking it.
Now I can call us.
സിനിമ ഷോ
എനിക്ക് ടോപ്പ് എല്ലാം
എന്തെങ്കിലും പറ്റിയോ എവിടെയും പറ്റിയ മനുഷ്യൻ തൊണ്ടയിലൊക്കെ കുടുങ്ങി കഴിഞ്ഞാൽ
ഒത്തടി
So R 26 millimeters, S 22. If we summarize, it's apparently 48 millimeters above 35. So it's a plus minus criteria. So compare these two leads with Spencer's different with different one. Your circumference are very for increased voltage, left ventricular hypertrophy. Look, R in V5, V6 plus S, sorry, V1 or V2. In one case there is the rod, in second no, but opposite. However, for now all you need to know is that the QRS voltage increases with left ventricular hypertrophy in left precordial. This is the end of it. V5, V6. And here it is like the reflection on V1, V2. This is S. Left ventricular hypertrophy. So these are variants. You may use them. You have any questions? If you don't have any questions, if you have, tell now. Because if I close, go in the corridor, you will come and tell, show me, I should come back. I'll not come back. Tell. Somebody has any questions? Please, announce. What? Oh. Unusual question, why? Because usually atrial infarction we don't have. First of all. Second, thanks. Second is that it is usually with infarction of left ventricle. So isolated atrial infarction we don't have. But if you want to know the truth, it is reflected on PR segment, PR depression. Infarction is by this, not only scar, but like infarction. Ischemia, ischemic injury, and necrosis. Okay? I think these examples are enough for you. Or not, I have textbook, you may take photos, but it will too much. If you need during consultations, I'll bring and we may continue. Okay? You have other questions? No? Okay. Happy New Year. See you next year.
Happy New Year.